Yes, good morning, good afternoon, good evening, everyone. Welcome po saan man pong panig ng mundo na naroon kayo. Welcome to our 88th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who have just discovered us for today, welcome po at sana po masiyahan po kayo at marami po kayong matutunan sa webinar po for today and for future webinars. We would like to also greet those po ang ating mga local viewers po na talaga naman pong masigasig at talagang sumusubaybay po sa ating webinar series. I'm talking about those from the provincial DOH office in Ifugao, Lagawe, Ifugao, from the Philippine Dental Association, Makati City, the Bureau of Quarantine in Zamboanga Station in Zamboanga City, Iligan City Health Office in Lanao del Norte, those from Nasipit District Hospital in Agusan del Norte, at lahat po ng ating mga sumusubaybay, nandito man po sa Zoom, sa Facebook o sa YouTube po. Maraming salamat. In the past few weeks, news of a sublineage of the Omicron subvariant BA.2 has been referred to as stealth Omicron. It has genetic mutations that could make it harder po to distinguish from the Delta variant using Pcr tests compared to the original version of the Omicron. The Omicron variant, as we all know, has been classified as a variant of concern by the World Health Organization and also being tracked by the U.S. Centers for Disease Control and Prevention. The WHO has also indicated that since BA.2 is Omicron, so ito po ay parte na rin po ng mga tinatrack po nilang variants of concern. For today's virtual international conference, ito na po ang ating ikalima, part 5 of our international conferences. We will be tackling stealth Omicron BA.2, what every frontliner needs to know. So if you are looking for the latest science-based and evidence-based information from the most distinguished experts, keep it right here. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday lunch date. Looking forward also to sharing hosting duties with my mentor, also our adjunct research faculty at the National Telehealth Center, also the President's Special Envoy for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie?
Hi. Hello, Raymond. Good afternoon and good afternoon, everyone. I'd like to welcome all of you. Ito meron tayong international conference. We'll speak a little bit in English, but we're going to translate as much as we can. And we'd like to welcome you to the webinar. This is, Raymond, I can't believe it. It's 88, the 88th.
That's correct.
We have organized, and we wouldn't be here without you. So we thank all of you for faithfully coming back every Friday and giving us a reason to try to bring you the best speakers. And I have to tell you, we have some of the best speakers you can get on this topic. And I know all of you want to hear more about this stealth Omicron subvariant. But before I go into that, I'd like to welcome our guests from the National University Hospital of Singapore, the Nagasaki University in Japan, Kyoto University in Japan, Chonin Hospital in Taipei, Bukit Mertajam in Malaysia, Can Tho City Hospital in Vietnam, the Ministry of Health in Oman, Riyadh Elm University in Saudi Arabia, Lonichi Ali University of Bilda II in Algeria, Stockton, California, Pasadena, California, the UP International Nursing and Healthcare Forum in Lexington, Virginia, Massachusetts General Hospital, Cancer Center in Boston, and the New York Presbyterian Vail Cornell Medical Center in New York. So we have a lot of guests from around the country and from around the world, and we'd like to just welcome you to this webinar. Now, in the news, Raymond, I was researching what stealth means, right? Because there was a movie called Stealth, right? And so I was looking at it. And the synonyms for stealth are very interesting. Secret, crafty, enigmatic, sneaky, silent, shifty. So I wonder why we call this subvariant stealth. And maybe we're going to hear that from our resource persons. But we do know that we heard about this first from Denmark and then India and then the United Kingdom. And I was looking at the news the other day, and Hong Kong had shut down about 16 blocks of apartment buildings where people could not leave the area because of stealth Omicron. So there is a lot we want to learn about this. It turns out that this is the most dominant form of Omicron in the Philippines today. We're going to hear about that from our Philippine expert. We will hear from our expert from the United Kingdom and from Singapore. So stay with us. This is going to be a fantastic webinar. So Raymond, over to you.
Thank you, Dr. Susie. So stealth usually conjures something along the lines of military affairs just because a lot of our aircrafts have those capabilities, but hopefully it's not as too sneaky as it is when we refer to stealth Omicron, at least for this variant. Okay, so we also have a very, very quick announcement po in preparation for our second year anniversary of the Stop COVID That's webinar series. TVUP, may we have it on the screen, our COVID-19 Heroes Memorial. We are calling for photos if you are also keen to share maybe stories of your family members, friends, colleagues with regards to how we can honor our global Filipino medical frontliners, those who have succumbed to COVID-19. Please, we do hope you're able to share with us. We are going to put them in a digital album and in a special audiovisual presentation. If you have a Filipino medical frontliner, family member, close friend, colleague, whether in the Philippines or across the world, whom you want to honor as part of the COVID-19 Heroes Memorial, we would like to request that you send a high-resolution portrait photo. The criteria is shown on the screen, at least 300 DPI with the following demographic information that we will be requiring, and send them hopefully via email before the deadline as shown on the screen. We would like to remember their sacrifice and honor their memory as part of our fight against COVID-19.
Yeah, Raymond, when we did this last year, it was a very touching moment, I think, for all of us to see so many Filipino health workers from around the world who, as you said, sacrificed their lives in the service of patients with COVID. So please send your photographs, names, and I don't know, it's like a small thing we can do, but we must never forget. We must never forget what our frontliners are doing, have done, and have sacrificed during this pandemic. So anyway, sorry, that was a little too serious, I think. Raymond, go ahead. Go to the next thing.
Thank you, Dr. Susie. Just to let everyone know, especially those who are joining us for the very first time, our webinar in Zoom can accommodate up to a maximum of 3,000 participants. So please join us so you can fully experience the interactive program. Those who are joining us in YouTube and Facebook, we would really appreciate it if you could also engage with us through the comment section, especially if you have any questions. We will try to pick up any interesting questions either in Zoom, YouTube, or Facebook. So please start typing in your questions if you have any. In parallel, we are also tracking any questions or any comments or feedback that may be written up and shown on the chat box and also in the Q&A box that we have here in Zoom. But hopefully, we're able to see a whole lot of you in Zoom. We are still a little less than 800 here in Zoom. So hopefully po marami po ang sumali. For those who are asking, we are working towards our CPD units, our Continuing Professional Development units for this webinar. And for those certificates of attendance po, no, for the previous 87 webinars, we are still trying to push out and disseminate all of those certificates, at least for webinar number 87. But for webinars 1 to 86, we have already sent them out. Please let us know if you have not received any certificates, and only those who have watched at least 50% of the webinar duration will be given certificates. For our today's webinar, we will have a panel discussion format with our three main speakers. representing 3 different perspectives from each of their countries. And we have then a Q&A session wherein we will be entertaining questions as mentioned. And we really are looking forward, very, very excited to a jam-packed webinar for today, Dr. Susie.
Thank you very much, Raymond. So for those of you who want to do Mentimeter, we're not having any today. So typically when we have an international conference, we go straight to our speakers because we want to give them more time to explain the subject matter and to speak to you. We encourage you to use the Q&A box, and our speakers have agreed to answer your questions directly. And you can use the chat box, you can use the Q&A box, but later we'll have an open forum. So without further ado, we are going to introduce our opening remark speaker, one of our favorites, your favorite as well. We know her very well. She's so hardworking. I would say oftentimes behind the scene, but really changing so many things in the field of research. So we have Dr. Eva Cutiongco-de, who is the Executive Director of the National Institutes of Health, University of the Philippines, Manila. Dr. Eva, welcome to the webinar, and please take the floor.
Good afternoon to our dynamic duo hosts, Dr. Susie and Dr. Raymond. And I'd like to welcome everyone to the University of the Philippines Stop COVID Deaths webinar series and today's virtual international conference. Now, let me thank the people who have made this program successfully running for almost 2 years now, right, Dr. Susie? You mentioned your 2nd year anniversary. So we have the UP Vice President for Public Affairs, Professor Elena Pernia, AVP Maria Angelica Abad, AVP Jose Wendell Capili, TVUP Executive Director, Professor Emeritus Grace Javier Alonso and her team, and UP Manila Chancellor Carmencita Padilla. Now, on my slide, this is the cover of the latest issue of the Time magazine. It is what everyone is interested in and hoping for, how COVID ends. So the story goes in this article that when the virus expert from the University of Massachusetts saw the mutations of the Omicron, he said it was like looking at the first page of a comic book and all of the Marvel villains got together and posed a big threat to the human race. But as it turns out, Omicron, like all villains, it has an Achilles heel. It does not cause severe disease for those who have been vaccinated or have previously been exposed. So people became more optimistic. Please click. The Time magazine article goes on to paint 2 scenarios. Please click. Scenario number 1 is that the SARS-CoV-2 virus has achieved equilibrium with humans. It may have found the right mutations that allow it to become more efficient at spreading from one host to another, while not causing so much disease that the host dies. It chooses transmissibility over virulence. Please click. Scenario number 2 is the virus could keep changing in unpredictable and possibly deadly ways. And the warning was that the next Omicron could already be out there, and yet we wouldn't know. Important strategies remain: improved global surveillance efforts and increased genetic sequencing of the virus, because knowing the genome of the circulating viruses can help provide the earliest hints of any changes and clues as to which of these changes could be dangerous for humans. And I'm pleased to report to everyone that the whole genome sequencing is about to commence in the different regions, spearheaded by the Philippine Genome Center Visayas and Philippine Genome Center Mindanao. And we hope to hear more about that from our Executive Director of the Philippine Genome Center, Dr. Cynthia Saloma, perhaps during the open forum. Now, this afternoon, the University of the Philippines, in partnership with UP Manila NIH National Telehealth Center, together with the PGH, has invited an outstanding panel of speakers from the London School of Hygiene and Tropical Medicine, from the National University of Singapore, Swee, Hock School of Public Health, and from the University of the Philippines, Philippine Genome Center. Thank you, Dr. Hibberd, Dr. Hsu Li Yang, Dr. Saloma, for accepting our invitation, and we look forward to learning more about the stealth Omicron from all of you. So back to you, Dr. Susie and Dr. Raymond, and welcome everyone again to this conference.
Okay, thank you. Thank you very much. That's Dr. Eva Cutiongco-de, and thank you for that great introduction. And I think what we want to do right now is to introduce our first speaker. So our first speaker, Raymond, is there anything else we wanted to say first before we go into our panel? No.
No, I think we should go ahead, Dr. Susie. We just wanted to mention that those who would be typing in your questions, especially those who have been our avid viewers for several webinars now, please start typing in your questions in the Zoom Q&A, and as well as the comment section of the Facebook pages, Stop COVID Deaths or TVUP, or in the TVUP YouTube channel. Dr. Susie?
Okay, great. Thank you for that reminder, Raymond, because we want to have more interaction. We don't have a Mentimeter, but we do want you to ask questions, and we will ask our resource persons to try to answer the questions to the extent that they can. Okay, our first speaker, Professor of Emerging Infectious Diseases in the Department of Pathogen Molecular Biology at the London School of Hygiene and Tropical Medicine. It is my privilege to introduce and to welcome Dr. Martin Hibberd. Dr. Martin, welcome to the webinar, and please take the floor.
Great. Thank you very much for the kind introduction, and I'm very happy to be here today. So let me just share my screen and let me get started. Hopefully.
Okay, you need to go into presentation mode, I think.
Is that okay now?
There we go.
You're good. You're good.
Great. So looking forward to get started. I think we have lots to discuss, so I'll move on. So we all know what COVID-19 is. It's a disease caused by the virus, SARS-CoV-2. And I think, when we started, we thought about the droplets transmission, something which is similar to influenza, and also through direct contact. But as the virus has evolved, and really what we're talking about here is this spike protein, the outer surface of the virus particle binding to the ACE2 receptor, which is on the human epithelial cells. So that's binding process is really the source of all of our troubles and problems. Because as this binding has improved, the virus has become more transmissible, and now we can see that the virus is found in smaller particles, and that means they can be suspended in the air for longer, and so you can have this more airborne transmission. And maybe there's also a little bit of indirect contact, which might also be able to spread the virus. So this spike protein found on the surface of the virus, binding to the epithelial cells in your nasal or your lungs, this binding is what's critical to that. And we use this spike protein for the vaccines, but also for the detection, and the virus uses it for entering into cells. So this, we know that the SARS-CoV-2 virus originated originally in bats. And we can see that the new virus is somewhat similar to the old SARS virus that turned up in 2003, and a little bit more distant related to those common cold viruses that we commonly experience. These are the coronaviruses that we see every year, and we have our nose sniffles from that. What's interesting is that all of these viruses are able to infect a very wide range of animals. We've heard about SARS-CoV-2 infecting zoo animals and ferrets in Europe and guinea pigs in Hong Kong. And that's because this virus is able to infect a wide variety. That spike protein binds to a whole range of mammals in particular, which have that same ACE2 receptor. And this is just a little bit of background for everybody, so we're all thinking along the same lines. This is a close-up of the virus particle with that spike protein on the outer surface, with those other components. And this, because we're going to be talking about the genome quite a lot, this is the whole genome of the virus with its different proteins represented across there. And here is the S, which is the spike protein. This is the DNA, the RNA that makes the protein on the surface of the virus. So those virus genomes have been sequenced from around the world, and this has been a worldwide public effort to try and understand those genomes and the differences. And this has been cataloged by this GIS-aid, which was originally set up for influenza, but was then put forward to the SARS-CoV-2. And this actually, from colleagues that we've worked together with for a long time. So I'm very pleased to see this initiative. If we look now at where we are in 2022, you can see that the virus is most numerous, is Omicron. But we can see a lot of these other variants which have occurred over time. And in the UK, for example, we had a big problem with Alpha. And then we had Delta, and you can see that during 2020-21, Delta was by far the biggest strain, and you can see there's quite a lot of diversity of that. But now we have Omicron. But I want to draw your attention to the fact that this is an evolutionary tree telling us when the Omicron first appeared, and you can see that it goes right back to the very early stage of the virus evolution, before March 2020, the Omicron occurred, and it's been in the background all of this long period of time, and now it's suddenly started to expand. And what we think happened is that this virus was not particularly good at transmitting at the early stages, but when it just recently, it suddenly acquired on this a whole set of new mutations, which has generated this new variant, which is more transmissible. And these variations occurred in a rush, in a very short time, and possibly through one person who was infected. And that we think this Omicron occurred in South Africa, maybe in a person who had immunocompromised, so didn't have a very good immune system, infected for a long time, and then generated all these mutations. And we saw that previously in the Alpha variant here, and that was first recognized in the UK. And this also has been around for a long time, and then suddenly became a highly transmissible variant. So if you ask me to predict the future, I would say maybe one of these early strains here, which we are currently ignoring, might be the next one to turn up. And it could be that it acquires a lot of these mutations that allows us to transmit more. So let me just spend one slide talking about my own work. This is work that we've done in the London School, thinking about what those mutations might mean. And here we've developed an analysis tool, so you can put your sequence data in and see whether your new variants are able to alter the immune response. How does it interact with your human immune system, and whether it possibly might be able to escape that. And here we're concentrating on that spike protein yet again, and looking again at this, the receptor binding motif, or that central part, which seems to be so critical for the changes that we're observing in the virus. So here it is again. So this is a 3D structure of the spike protein binding to that ACE2 receptor. And you can see in red here these different mutations. And those are the things that we're talking about. And that allows this spike protein to bind better or worse to this ACE2 receptor. And here are these different variants from the World Health Organization giving us their names, but we also have these lineage names, and these are the different mutations across this spike protein, which lead to these different characteristics. And one of those, in a little bit more detail, we can see this is the Wuhan, the original strain out of China. And these are all the variants which were came from that original virus that have been changed over time with all these different new variants. You can see that all of the new variants have this 501, a different mutation here. So this is important for allowing these to become more transmissible. But you can see there are differences between the alpha variant, the delta variant, and Omicron. And actually Omicron, as you can see here, has got by far the most variations from that original Wuhan Chinese strain. So why is that important? Well, it's because of the PCR detection system. We know how we can detect with PCR. We look at the sequences of these different viruses. We take the nose swab, we do a PCR test, and typically the PCR test looks for 3 genes within the virus. It looks for the N2, the nuclear protein, the envelope protein, and then this critical spike protein. And we've already heard that a lot of the mutations that are causing these variants are in this spike protein. And so this is the one that suffers from these mutations that might affect the PCR. And right now, we're detecting Omicron without having to do the sequencing by comparing it to the Delta virus. And we can do that by looking at whether this spike protein is detected or not in the genome. So is the S gene detected? Yes. It's currently unlikely to be Omicron, and no, well, it could be Omicron. But you need to confirm this with the full genome analysis. But let's have a little look at what's happening in the previous variants. So we had the original Wuhan, where the PCR was designed, and it detected these 3 genes. When Alpha turned up in the UK and then traveled all the way around the world, it had this dropout. The mutation in the spike protein stopped the PCR from detecting that. And so we could detect Alpha by comparing it to Wuhan. As Delta came along, first described in India, actually the spike detection came back, and we could detect all 3 gene components again. Omicron, as we just heard, it again dropped out the S because it gained this mutation. And now we have the Omicron BA2, the so-called stealth one, and it's actually the detection has come back again. And so we've now unable to distinguish the Delta variant from the Omicron variant, although we can now distinguish between the original Omicron and the BA2 variant using the standard 3-test PCR. So we'll hear more about this later, but the original Omicron is the BA1, and you can see this is a lot of diversity building up now around the world as it spreads there. But BA2 is a distinct lineage and goes right back perhaps to August 2021, and it's been isolated and developing in its own path since then. And we can see that that's developed a number of different mutations as a result of that, and that variation is building up. However, at the moment, we don't see any clinical differences between the different variants of Omicron. So while the PCR is distinguishing those and the BA2 can be called a stealth, it's still not any different clinically, fortunately. I want to spend a few minutes now thinking about the what's happening in the UK at the moment and where we've come from. So I've shown here a plot of time. So when we started first cases in the UK back in March, April 2020, and this is UK's new coronavirus cases per day, and it's the rolling average of the week. So you can see that there was a small number detected in April 2020. We had a peak with the Alpha variant back in the winter of 2021. Then we had Delta came out in July, and now we're just past the peak of the Omicron variant in the UK. If you look at that, it looks as though Omicron is much more spreading than the original Wuhan or even the Alpha strain, but there's a reason for that. That's because the testing has been rather different. But in the UK, we've been lucky to be able to do a national survey of people with the virus. And this is the recent results across the UK, where we've tested a random proportion of households throughout the UK and tested them to see how many of them actually have COVID. And you can see from that, rather than just counting the incidence or the number of cases reported, we can get an estimate of the total numbers. And you can see here the percentage of all of those people randomly selected, how many were positive for COVID-19. And you can see it right at this current time, we've got Omicron, and we're testing about 5% of the people being positive. And if we look in a little bit more detail, you can see that that's slowly coming down, by the 12th, 14th of February, which is our latest survey. But that still means nearly 2.5 million people across the UK are currently infected with Omicron. So that's looking at the number of cases. This is looking at the number of people with in hospital. And here we've had much better, more consistent testing. And you can see that we have a clearer idea of how many people. And when we do hospital testing, the number with Wuhan and Omicron look much more similar than when we look at the general population. And you can see the UK suffered the most with the Alpha variant as that came through back in the end of 2020, beginning of 2021, our winter season. And if we look at the severity or the, sadly, the deaths that have occurred, you can see that in the early stages, when they first arrived, there was up to nearly 1,000 deaths a day in the UK. With Alpha, that moved up to nearly a maximum of 1,800. We had Delta at this stage, and then we've got Omicron. And Omicron has, on this particular day, which is Valentine's Day, there was 35 deaths at that point. Let's put that all together and try and think about that in context a little bit. So if we look at the cases, how many cases were reported, at the early stages, we were only testing in hospitals and the numbers were pretty low across. If you weren't in hospital, you weren't tested. By the end of beginning of 21, we were doing PCR testing with everybody with symptoms. And you can see there's a lot more cases reported. And then from July last year, we had widely available self-testing, and then the number of cases reported went up dramatically. If we look at those in hospital, you can see that we had a big problem when the virus first arrived. The UK locked down and those numbers dropped. We opened up and the cases went back up again. And this is when we're talking about the Alpha wave. With those high numbers of people in hospital and the deaths, we locked down again. And then in July, opened up again. And we've had a fairly steady state with kind of minimal interventions at this point. And this is when Delta arrived into the UK. And then with the arrival of Omicron, which is more transmissible, we've seen a rise in the number of cases and the rise in the number of patients in hospital. And the other big difference, of course, is those first two waves with the number of deaths that occurred matched the numbers in hospital. But since this Alpha wave, we've had the vaccines, and that's leading to a much smaller proportion of deaths compared to those two previous waves. So during Delta and Omicron, we've had vaccines and a smaller number of deaths. In fact, if you look at those waves, the Alpha wave, the Delta wave, and the Omicron, if you look at the number of cases, we can see clearly that Omicron had more cases, but The number of hospitalizations was lower with a maximum from Alpha, Omicron, and Delta wasn't that high. And if you look at deaths, it was by far the biggest problem in the UK was with Alpha, with Delta and Omicron. So while in the world we think of Delta as being more severe than Omicron, actually we've had less deaths in the UK from Delta, because when Delta arrived, we had the lockdown and we had effective vaccines. In the UK, it's been very good at rolling out vaccines. We've been dosing recently up to 1 million people a day with the booster doses. And you can see that we've concentrated with an age effect. We've been looking at the older age populations, which are more at risk of disease, and we get more than 90% of the older population have been vaccinated. And that's why we can show that the death rate has reduced dramatically with the Omicron infections. And just to say that, why the UK has been going ahead with its third booster dose is because of the escape that Omicron can do compared to, previous infections. So we've now got a large amount of data coming through looking at reinfections. And this is a kind of estimate of how many reinfections are occurring. And because you have to account for time as well as people, we're looking at reinfections per 100,000 participant days at risk. And we get a value for about 11.7 for Delta. But you can see that Omicron is more than 10 times able to do reinfections compared to Delta. So Omicron is much more likely to reinfect you for a second time. So with our large amount of data, we're able to do a comparison about the different age groups. And what we've been trying to do in the UK is keep this group, the 60 plus, in this higher risk group low. And you can see that during last year and up until our winter season, we've been quite good at keeping those numbers low. And Omicron arrived there's been a peak. But look, it's interesting to look at the children's group here, under 19s in this graph, and you can see which is in red, and you can see that we've had peaks, and this is corresponding to the schools opening and closing during their holiday periods. And we can see that we've kept schools open in the UK, and that has led to quite a few cases amongst children. In fact, that's where most of the Omicron has been occurring recently, has been in the children's group. But we've managed to keep the schools open by these widespread testing, and children test regularly, twice a week, or if they have symptoms, they also test. And if they're positive, we keep them home. So they have to isolate at home. They're not usually very sick at all, so it's just a matter of isolating at home. So this is the UK's effort, and we can see that in the early stages, UK had relatively poor response. So UK is here in this color, but we can do a comparison about what we did and how well that responded. And every country's had a slightly different approach and with a slightly different result. And we can learn some lessons from that. What gives you a good outcome for your countries? Well, the top one is obviously vaccination rate. If you can get your vaccination rate, particularly in your vulnerable groups, that's a huge advantage. But we also know that the age profile of the country, if you have an older population, such as in the UK, that's more of a risk. And if you have the older population with comorbidities, that's also a risk. So the Philippines is a younger and less comorbidities than the UK, so that's all good. But look at these other factors. So essentially, it's how likely you are to meet a positive person. So that's social mixing, your contact rates, do you have to do public-facing work, or can you work from home? Is there your family mixing? Is there a large number of people living together at home? Whether your healthcare access is good, and your self-isolation support. So all of those things talk about an economic factor. And if you're, that's why COVID is becoming more of a disease with those with less economic means. So just as a summary, I think, pandemic to endemic, this is what everyone is thinking about now. So COVID is a nasty new disease that is here to stay. I don't think we're going to get rid of that. And that's because it's so widespread in humans around the world, and also found extensively in animals. So there's a reservoir. It's always going to be able to come back. My prediction is that there's going to be new variants each year, and we need to monitor for those in the same way we do for influenza. For influenza, we take a sample of those and we make a new vaccine every year, which protects those vulnerable people from a new influenza strain. And my feeling is that we're going to have to do that with COVID as well. And that means then your vaccination needs to be updated every year. I'm hopeful. I think new, longer lasting and broader response vaccines are on the way, but they haven't been trialed yet. And the other good news, I think, is that we have therapies that have come through. So these are direct antiviral therapies, and those will offer help to those people that haven't been vaccinated or have got disease despite vaccination. But to make the most of those, we need to test, find out early, and treat patients early. So that's the end. I'd just like to say that I've been doing my best to do a little bit of public speaking, and I've been engaging as much as possible. And I hope this talk has been useful, and I'm happy to take questions later. So thank you, everybody.
Thank you very much. That's Dr. Martin Hibberd of the London School of Hygiene and Tropical Medicine. Excellent presentation. I think you'll see in the chat how much our audience appreciates the clarity. And I think looking at the how the pandemic unfolded over time in a place like the UK is really something that pushes us to think a little bit more about how this pans out in the future. So thank you so much for that. And I'm going to turn, and we'll have you, Martin, for the Q&A later. And if you have some time and there are questions in the Q&A box or the chat box, please feel free to answer them. I'm going to turn over to Raymond now. Raymond, go ahead.
Thank you, Dr. Susie, and thank you, Professor Martin, for just giving us a quick backgrounder on the BA.2 sublineage of Omicron, and for sharing with us the situation in the United Kingdom. We've received a few questions with regards to your presentation. We hope to be able to get your answers to these questions during the Q&A. Our next speaker is the Vice Dean for Global Health and a Program Leader for Infectious Diseases at the Swee Hock School of Public Health at the National University of Singapore, was also the former Clinical Director for the National Center for Infectious Diseases, and also the former Director of the Singapore Infectious Diseases Initiative. Please welcome to our webinar Dr. Hsu Li Yang. Dr. Li Yang.
Hello, everyone, and thanks very much once again for the opportunity to be here. I think it's wonderful to see how many people are here listening in, and you really have organized something fantastic. I was asked to talk about the COVID-19 pandemic in Singapore, which is a good thing because I'm not sure I can share very much about the BA.2 lineage of the Omicron variants after Martin's excellent talk earlier. So this is the main things I'll talk about. I'll give you some statistics about Singapore and how Singapore has approached major epidemics, and then we'll go through some of the key moments in the pandemic. I do receive funding from several pharmaceuticals, many of whom have produced products or vaccines that's related to the pandemic. But let's get started. So this is where Singapore is now with cases. And you can see, for instance, that for a long period of time, when the pandemic first appeared to sometime this year, Singapore had this approach where we tried to limit the cases spreading in the community. We even had a circuit breaker, which I guess is a different way of saying lockdown. And between January 2020, where we had the first case, and 2021, we kind of kept things under control, except for the outbreak in the dormitories. And then we had the first Delta case in April of 2021 last year. It took a few months before there was a big jump in cases. And then we had the first Omicron case in December 2021. And you can see that this Omicron came as the Delta wave was receding. And on not too long after, less than a month after, on about the 22nd or 23rd of January, we realized that we have the BA2 sublineage or subvariants of the Omicron with us as well. And the case count has been rising so far, although we don't sequence every single virus that we isolate. Nonetheless, between January 2022 and now, the proportion of cases that's due to the BA2 variants has jumped to 50% or more, which took place in less than 1 month. So you can see the replacement of the different variants as what Martin has described, which no doubt you're seeing in the Philippines as well. How about deaths? So you can see that the deaths kind of tally and follow after the cases, right? We had a number of deaths at the beginning of the pandemic, but it really started to increase when the Delta wave happened. And now we are seeing the deaths rise again in Singapore as the Omicron variant spreads and infects more and more people. I think we have more than 10,000 cases, about 16,000 cases reported yesterday, which is quite a lot for a small country like Singapore. And then this is our vaccination rate, the proportion of cases who died by age and vaccination rates. Although I think close to 90% or more of our population, of the whole population, have now been vaccinated. But nonetheless, there are still people who don't want to be vaccinated or cannot be vaccinated. And it's about almost an 8 times higher death risk for them, especially for the older age group, if they are not fully vaccinated or boosted. I spoke a little bit about our vaccination rates, and this is one of, I think, Singapore's success stories. We managed to obtain the vaccine early, and we roll out mass vaccination fairly quickly as well. Not as fast as UK, but we kind of caught up somewhere near the end. And you can see that for different age groups, we have reached more than 85%, and in fact exceeding 90% for both completion of vaccination, with close to 64% of the total population having received the booster dose as well. We started rolling out the vaccines for children aged 5 to 11 at the start of this year, and that's gone over 35% of all children aged 5 to 11 being vaccinated at this point in time. How do we approach pandemics? I think, unlike several other countries, Singapore was one of those unfortunate countries that experienced SARS in 2003. That first SARS epidemic was like a major wake-up call to us. And we tried to think about what we would do if future epidemics hit us. Right? Our response to SARS was not the best, but fortunately SARS, unlike the COVID-19 virus, spread less easily between people. So I think we decided that major epidemics would require a whole of government approach, not just the Ministry of Health, because it was quite clear that it affected whole segments, large numbers of segments of the government machinery and the population as well. So there's always been a whole of government approach with a large multi-ministry task force set up to deal with epidemics, and that served us through the 2009 pandemic, when Zika hit Singapore in 2016, and other things as well. So the multi-ministry task force in Singapore was set up prior to the first case coming in, and it's set to direct all parts of the government response to the pandemic. And this is broadly the COVID-19 strategy in 2020, at a time when there was no vaccine and no effective treatments. The key to us was to try to reduce the number of cases as far as possible, doing a few things that Martin has already mentioned, which is to try to improve the surveillance, to try to find as many cases as we can, and then to isolate those persons as well as their close contacts. And of course, what every country did was to try to reduce importation. And we also strengthened the healthcare capacity to deal with the pandemic. But I think nobody expected the pandemic to last as long as we did. And the pandemic also highlighted weaknesses in Singapore, things that we had kind of overlooked, blind spots in how we had looked at the Singapore as a whole. And the one shock to us very early in the pandemic was when the migrant workers living in the dormitories were affected. Singapore is largely dependent on migrant workers. And actually, we have a lot to thank the people of Philippines, because you know very well that that many of the nurses in Singapore, a large proportion of the nurses in Singapore are from Philippines. And we have many domestic workers who are from Philippines as well. But this outbreak occurred amongst migrant workers who are living in dormitories. And there are close to 250,000 of them in Singapore, living in some 40 over dormitories. So each dormitory can have between 5,000 to 10,000 persons, and they tend to live in fairly crowded conditions that you can see in these pictures here. So in April 2020, when the dormitory started to be affected, then we realized we had a huge problem on our hand, because there was no way that you could isolate 250,000 people such that they didn't get infected. And a separate task force was set up to deal with this outbreak that lasted from April to August 2020. And you can see from here that what we actually did was to close down the dormitories and then to put in place medical outposts there. And of course, to be sure that the workers receive food, they receive the medical treatments, and most importantly, they receive their pay, right? Because this is a terrible period for the workers who are shut in the dormitories for many, many weeks. And I think this is still the one single blight on the whole of Singapore's response to pandemics and our response to these migrant workers. We also set up facilities like what you can see. This is the Singapore Expo that used to have huge concerts of more than 1,000 people. Well, since nobody could travel, they were converted into facilities for taking care of COVID-19 patients who did not require hospitalization. So that's one key moment. And then the second key moment occurred when we had a Delta wave. At this time, which is after August to December and then in 2021, we were kind of happy with what we were doing. Right? The case count was less than 10 every day, and things were okay, and we were preparing to open up again. And then we had the Delta wave. It occurred in airport workers who were wearing PPE. It occurred in our main hospital that was taking care of the patients during the pandemic, Tan Tock Seng Hospital, and everyone was wearing a PPE with N95 mask as well. And then this cluster started to grow. And I think at that moment, we realized that when you had a virus like as transmissible as the Delta variant, which is between 3 to 6 times more transmissible than the original Wuhan virus, then we decided that there was no way we could keep the numbers down anymore. And then the strategy changed to trying to vaccinate as many of the population as possible, while trying to keep the numbers low enough so that our healthcare system wouldn't be overwhelmed. And that brings us to vaccines, and again, an area which I think Singapore has done reasonably well. Even prior to the vaccines reaching a phase 3 in clinical trials, we had already formed a therapeutics and vaccines expert panel that just didn't comprise of medical doctors and scientists, but also the economic development boards, private sector individuals from the pharmaceuticals and all that. And the whole point at that time was to try to give advice on which vaccines to bet on so that we could kind of purchase them in advance, because we could already see that around the world, there would be a mad scramble for vaccines once they were available. And Singapore being a small country, the strategy was try to purchase them early so that we wouldn't be left out at the end when I guess the high income countries from the West started to corner the markets in these vaccines, right? So it was, I think, one signal moment of success that we managed to get the first mRNA vaccines into Singapore by December 2020, and then to roll it out in the population. So the vaccination rollout, again, was a huge exercise, and I think Philippines and UK, there were the same kind of processes undertaken. In Singapore, we had a progressive rollout. Healthcare workers first, frontline workers, those who are most vulnerable to the pandemic, such as elderly, and then we went down the line, right? And young children have come last, as the evidence showed that the vaccine was both safe and effective in them. One of the reasons for this kind of a slow rollout was that we also had vaccine supply issues. There was just no way that we could get enough of the mRNA or other types of vaccines into Singapore in large enough quantities to vaccinate everyone. So we kind of had to adjust to the vaccine supply as well. But all over Singapore now, there are vaccination sites that are open for people to walk in and to get their second or their booster doses with facilities on site, so that if, touch wood, something happened, they had an anaphylactic reaction or whatever, they could be taken care of, right? Then I think this is something that Martin didn't touch on, but maybe you have experience in UK, in Philippines, and the other countries too, and that's misinformation. And this is something that still boggles me, right? With COVID-19 and then with the rollout of the vaccines, suddenly there was a huge spread of misinformation about both the pandemic as well as the vaccine. And even members of the healthcare community, including doctors, stepped up to say that the vaccines are not safe. The vaccines cause a lot of different diseases. The vaccines are more dangerous than the virus. And Singapore had to have a response to this kind of misinformation as well. Previously, we do not have much of an anti-vaxxer problem compared to Europe or US. But for the first time, we had websites, WhatsApp groups, and Telegram groups dedicated just to the spread of misinformation about vaccines. And that was really cold reality that stared us in the face. But I think in Singapore, again, we aren't as vocal as many parts of Asia or Europe. And so this also didn't affect very much our vaccination rollout, which, as you can see, has reached 90% of the people. And then I guess near the end, we talk about the testing strategies. Initially, we had problems with testing supplies as well, especially in the early part of 2020, when there just wasn't enough PCR machines or even reagents to do the testing. And we had debates about which was the better form of testing, whether nasopharyngeal or saliva, or you swab the mouth and the nose together, right? And we had to fit in things like serology and antigen rapid tests or lateral flow tests, which I think are the main means by which we in Singapore and many other countries detect COVID-19 now. We have always had viral whole genome sequencing. Martin knows this well. GIS8 was also set up by colleagues from Singapore who collaborated with scientists around the world. And so we have always been sequencing the viruses as they came in, and which is how we knew when we had the Delta, when we had Omicron, and now when we have this BA2 variant. As far as the BA2 variant is concerned, currently we are not treating it any different from the Omicron, although I think there is some worrying information that has been preliminarily released about how some of the monoclonal antibody treatments like sotrovimab don't work so well against the BA2 variants. I think we are waiting for GSK to confirm this before we think about whether we should do something different for the BA2 subvariants of COVID-19. So at this point, there is EvoShield in Singapore, the combination monoclonal, which we give to relatively sick patients or those at higher risk of disease. We don't go down to determine whether they are BA2 or Omicron at this point in time. But I think as the treatment differs for cases who are at higher risk or are more ill, then we have to think about testing strategies that allow us to detect the BA2 or future variants so that the management can be a little bit more directed and precise, right? So we have moved the whole gamut from isolating everyone with COVID-19 in a dedicated facility to now telling people just stay home. You can come out again when your antigen test is positive, even though we understand that the sensitivity of the antigen rapid test far lower than the PCR test, right? Sensitivity is only about 80% and only useful for the first few days. And that kind of brings me to the last part, which is that now that we have gone through more than 2 years of the pandemic, what is the way forward? During all the key moments I've shown you with all the different variants that come to Singapore, we have realized that we cannot keep the virus out. The Singapore economy, unlike China, will not survive. And by the same time, we have done our best to protect the population with, some would say, rather coercive measures to push people to get vaccinated without making it mandatory. So at this point, I think we are still one of the most cautious countries with regards to stepping down restrictions. Everyone still wears a mask when they go out, or they'll be fined about $150. And we don't know when that's going to change. But I think every one of us is now looking forward towards all these restrictions being stepped down and kind of integrating with the rest of the world again, touch wood, with our new, more dangerous variants coming up in the future. So I'll stop here, and thanks very much for giving me the opportunity to speak to all of you.
Thank you, Vice Dean Li Yang. It was really an eye-opener with regards to just in contrast with how the UK has been doing with all of their restrictions and their measures, and in comparison, how strict Singapore continues to be with regards to all of those measures. There are a couple of questions that's very much targeted for Singapore, but we'll put them aside and we'll tackle them during the Q&A. Thank you, Vice Dean Li Yang. Dr. Susie?
Yeah, thank you very much, Dr. Liang. I thought that was really a great presentation. We all watch what's happening in Singapore because it seems Singapore is ahead of the curve in the ASEAN when it comes to the response. And so hearing from you about the details of how you're managing and the challenges that you see currently, this is very good for all of us, and I think our audience really appreciates this. Okay, so we'll go to the next speaker, and of course we will not have an international conference without a Filipino who's going to speak and itaas ang bandera ng Pilipinas. We are very proud to have with us representing the Philippines in this international webinar. Somebody you've met before, pero kilala natin siya dahil kung nung una natin pinag-usapan yung genome sequencing, she was the one who came and explained this to us. So it is my honor to present the Executive Director of the Philippine Genome Center. She's trained here in the Philippines and in Japan, and has been with us a couple of times, but she's here to talk about the Philippine situation. So Dr. Cynthia Saloma, welcome to the webinar, and please take the floor.
Thank you very much, Dr. Susan and Dr. Sarmiento for the invitation, and also to Martin and Dr. Lee. Now I'm going to give to you a on-the-ground analysis of the BA.2 that we have found here in the Philippines. I have not incorporated so much about some of the public health measures that our government has done, but I'll try to see if I can remember and incorporate these in my discussion. So today, I'm going to talk about the updates on the Omicron variant BA.2 in the Philippines. Dr. Martin has already told you about the reason why this was called stealth Omicron, so I'm not going to deal into that one. And we'll go down to the data that we have. So as of February 2022, there have been 418 million cases reported worldwide, with 5.4 million confirmed deaths. In the Philippines, we have 3.6 million confirmed cases and about 55,000 deaths. So the impact of this pandemic is expected to be felt for a very long time, not least of which is because we don't really know the trajectory that this virus will take. So this is the summary of the SARS-CoV-2 variants that we have detected at the Philippine Genome Center. As a background, when we went around Southeast Asia as well as in the US, when we were trying to conceptualize a genomic center here in the Philippines, we went to Singapore, we went to Taiwan, we also went to Hong Kong, and of course in the US. And we realized that one of the imperatives of having a genome center here in the Philippines was the possibility that of a pandemic, and that if there is a pandemic and that borders will be closed, we don't have a mechanism or a way by which our samples can be sequenced. So those were some of the reasons why in 2009, 2011, we had a Philippine Genome Center DNA sequencing core facility that was helped by the Department of Science and Technology. So now we have here the summary of our Omicron cases in the country. And in the beginning of 2021, before the end of 2020, we were actually called by the president of the Philippines, and we're asked if we have a way by which we can detect the B.1.1.7 or the variant of concern called eventually the Alpha variant. And it was an opportune time because the Secretary of Health brought us there together with Dr. Eva to show to the president that, oh, we already have a facility that is ready to do whole genome sequencing. And at that time, we also had some sequencing kits, the COVID kits, which we were able to procure through a PCHR grant. So our first cases of COVID, the first variant of concern we have detected was on this January 3, and that was in Cordillera Administrative Region. So that was the first time we were able to detect and, of course, utilize the Philippine Genome Center in the national genomic biosurveillance effort. So this is current as of February 5, 2022, and this is a summary of the SARS-CoV-2 variants we have detected in the Philippines. So to summarize, so far, I think for whole genome sequencing, we have done about 23,000 whole genome sequences. About half of these have been uploaded to GSA. The others are awaiting approval from the Department of Health before we can upload to GSA. Okay, so if we look at the alpha cases, alpha variant cases, we have about 3,000 and about 3,000 beta cases. In many countries, there have always been more alpha cases than beta cases, but in the Philippines, we actually have more beta variants than alpha variants. And then the Delta variant, in terms of cumulative number, we have about 8,651 sequence already. But in the beginning, towards the end of 2021 and in the beginning of 2022, it's all practically Omicron variant. So you can see here that all of a sudden we have so many Omicron variants and we could hardly get any Delta or the P.3 Theta variant of interest. So this was one which we detected originally in Central Visayas in January 31 to February 2, when they had a spike of cases. And when we did whole genome sequencing and mutation analysis, we realized that we are looking at a potential local variant that was very similar to the Gamma variant of Brazil. So eventually it was declared as a variant of interest, but eventually, of course, it was relegated into a variant under monitoring by our government because it apparently did not spread so much around the world. But this has also some telltale mutations that were concerning. Okay, so we will see here that we have all Omicron variants. If you look at the emergence and evolution of the SARS-CoV-2 variants here in the Philippines, and this is from outbreak.com based on the sequences we have shared to this date so far, this is only based on 13,000 sequences. You can see, for example, that in the months of March to May in the Philippines, we have a lot of alpha as well as beta variants in our sequenced cases. So the green one is the alpha and the red one is the Delta variant. And if you really look at very closely, the cases went down by May. And then by July of 2021, we're looking at a spike in cases, a very fast spike in cases that were of the Delta variant. If you look at the epidemiologic curve of the Philippines here, so you remember, you can see there seems to be a small wave here, and this is really because towards June of 2020, the Philippines opened our airports to returning overseas Filipinos. So between March 7 or March 17 to May 31, 2020, our borders were closed. So we had a lockdown. No one was allowed to enter the country, no visitors or even returning overseas Filipinos. But eventually we allowed our returning overseas Filipinos to return in June of 2020. And that also marked the detection of the D614G variant. So you can see here, for example, there is a small wave. A lot of our frontliners requested that should be a circuit breaker so that we will be able to rest and of course to strengthen our health capacity, our health system. So we had a rest sometime in August or September. Then eventually the UK and the WHO announced the discovery of a variant of concern called Alpha. And that was the time when we were called to Malacanang to discuss on the country's measures, and from the Philippine Genome Center side, if we can help in the genomic biosurveillance effort that is being done, the genomic biosurveillance effort that is being led by the Department of Health. So that was the beginning of our involvement in this process in a whole of government approach. So we first detected the Alpha variant from Filipinos returning, coming from the United Arab Emirates. And of course, we have also, but the earliest Alpha variant, when you look back at our biobank samples, it's really from a overseas Filipino worker who came from the UK. So that was December 12, 2020, but apparently we did not have any onward transmission in the early part of December. So eventually we had a rise in cases, and this was a time when we also detected the Beta variant. Amazingly, the Alpha variant we mostly detected first in the airports and our ports of entry. So the government had quarantine measures in place. But the Beta variant we detected in an area surrounding the airport. So this was in the community around the area of Pasay. And when we were requested by Central Visayas to sequence some of the cases where they had a rapid rise in cases, that was the time when we discovered that we have a local variant, the Theta variant. So now it's just called P.3. So you can see that this curve is actually a combination of Alpha and Beta and some Theta, most likely limited in certain regions of the country, such as Region 7 and some on the National Capital Region, and it's spill over in Region 6. So up to July, so this there were a reduction in cases by May, but by the beginning of June, July, we observed a rise in cases of the Delta variant. So by August, about 90% and above of sequenced cases coming from the National Capital Region were really already of the Delta variant. So you can see here that the waves are of course associated with in introduction or the rise in cases associated with our variants of concern. So we have the Delta wave, Alpha or Beta wave, and of course now we have the Omicron wave, which we first detected in December at the time on the tail end of the Delta variant cases. So we thought we could rest for a while. Indeed, we rested for a while in December, but actually, unbeknownst to us, by the third week of December, the dominant variant in the Philippines was already the Omicron variant. We also noticed that in contrast to some of our Asian neighbors, particularly in Southeast Asia, the peak of cases for the Delta variant in the Philippines is about a month or 2 months later. And probably that is a reflection of some of the border controls that our government has initiated. And also take note that in the Philippines, we do not allow, or we did not allow face-to-face classes. So our elementary students, high school students, and college students are still studying at home. Okay, so this is the Omicron that has become the dominant variant in the Philippines by the last week of December 2021. So you can see it was a very, very rapid rise in cases. Our earliest Omicron was detected on December 22, and that was a BA.1. Our earliest BA.2 was a local case, and that was detected in Mindanao on December 2, 2021. So the actual number of confirmed COVID cases dwindled toward the end of third week of December. So you can see here, for example, and we also had difficulty asking people to send us samples from different parts of the Philippines. But eventually there was a rapid increase in cases, particularly after the holidays. So that was in January of 2022. So when we were looking at our sequences, there was something interesting about the sequences that we have been analyzing, and that's why that's what I will be sharing with you today. So this one is, again, luckily we have now a caseload of about 2,000 level every day, probably lower before the end of the month. So it seems as though we have already reached the peak in Omicron. We are earlier than some of our Asian neighbors in terms of Omicron cases. We had a very, very rapid rise of cases. We peaked in about the second week of January with about 39,000 cases, but eventually it rapidly declined, and now we are at the level of about 2,000 a day. So what is the story behind this? So if we look at the cases as shown by Martin for the UK, the rise in cases and the concomitant equivalent rise in the number of deaths, and that was true for the detection of the D614G in the Philippines in 2020, in the middle of 2020, and also for the detection of the alpha and beta cases between March to May of 2021, where we had a lot of deaths also. But this was also a time when there was a move to vaccinate. The Philippine government was able to secure vaccines to vaccinate our frontliners. So I think the earliest was in the first week of March, we tried to vaccinate our frontliners, our doctors, nurses, on all those working in our hospitals. So that was in March, and as the samples or as the vaccines, the number of vaccines became more and more, then we increasingly vaccinated also A2, A3, some of the priority groups, particularly those with comorbidities and those who are senior citizens. I would like to point out how also that when there were cases for Delta increased in the national capital region, there was also a drive to vaccinate as many people as possible in the NCR plus region, because this is the region where we have the highest number of cases. So as we speak, I think the vaccination rate for the national capital region is very high. Sometimes it's the values they give is beyond 100%, it's 103%, only because the target population has been exceeded, since NCR also vaccinates people from outside of the national capital region. So the vaccination rate within the national capital region is actually quite high. And that was also probably the reason why our presentation of cases with Omicron is not as severe or even also for Delta. So when you look at the Delta cases, the Delta actually is a long period, probably from July to November. And this is also a time when we had lots of deaths. But compared to the Omicron, where we have a very sudden rise in cases, we have a decoupling in terms of the number of deaths, and that could be because of vaccination, prior infection, and of course of the innate quality or characteristic of the Omicron virus itself. So what is the regional distribution of Omicron cases in the Philippines? So far we have detected 3,230 Omicron cases, 2,795 of which are local cases, and they are found all over the country. So you can see here, there are now how many 3 lineages? So the original B.1.1.529 Omicron is actually now subsumed into BA.1 and BA.1.1. So, and then of course you have your stealth Omicron BA.2. So the red one here are for our returning overseas Filipinos and some international travelers. So you can see, for example, that all over the country, in the 17 regions of the country, we have already detected the BA.2 variant. Not so much with BA.1, because the BA.1 we normally detect among our international travelers and returning overseas Filipino workers. So there has been recently an uptick of BA.2 cases from returning overseas Filipinos, and this reflects also the global trend where they have been seeing cases of increased detection of BA.2 in the UK, also in India, and also in portions of Europe. Denmark, for example. So let's continue. But what is amazing about the Philippine cases is that 98% of our local cases are under BA.2 sublineage. So 98% of sequenced local cases of Omicron are under BA.2. So you can see that in contrast to the fact that BA.1 coming from international travelers arrived much earlier. Our earliest detection was November 22. It did not really gain some foothold, or it might be also a manifestation of the fact that our quarantine measures are working, because we could hardly see onward transmission from our overseas Filipino workers returning into the country. But even that, it does not preclude the possibility of certain founder events, the hidden lines of transmission, which have led to the rapid local spread of BA.2. So what is the story about BA.2? The Philippines, for example, in other countries, and India and the UK, as well as now Hong Kong, they have detected as much as 50%. In the Philippines, as early as January, the number of BA.2 was really, really high. But this is just not usual BA.2, because we also found mutations in the BA.2 that are circulating locally in the Philippines. So far, we have not found any clinical significance about these additional mutations, but it would be worthwhile to share this to you. So this is the sublineage. This is the global sublineage. So you will notice that the BA.2 increasingly, the latest count in GSAID in the global database, is now 21% BA.2, and that we hardly get. So they have already, quote unquote, removed B.1, .1, .529 and divided this into BA.1.1 and BA.1. But this is a very, very interesting data from the Philippines. And this is from the first 500 cases we have. So we now have 3,000. What did we observe? So among our international, so this is based on lineage. So we have local case. So this is based on Omicron lineages, BA.2, BA.1, BA.1.1.529. So there's actually a much later data with BA.1.1. But this is just to show to you, with the first 500 cases we have, we observed that among international travelers, the returning overseas Filipino workers, and some international travelers, the lineage that they bring to the country, of course, they are quarantined, is BA.1. But what we observed in our local cases, in our community transmissions, is BA.2. And this was very, very significant. And it is also part of the reason why our government opened our borders, because the transmission of the virus is not so much because of fresh introduction events coming from the airport, but it's really driven by local community transmission of BA.2. Now, many of the local clusters exhibit a tree topology consistent with exponential growth and community transmission. And there seems to be no clustering based on location, but we observe, for example, that these yellow ones, these are national capital region samples. There seems to be a temporal change, of course, where the early cases have been detected in the national capital region, and then there's a fast decline of cases in the NCR. And now we see cases spreading in nearby regions around NCR first, and then of course in Luzon, as well as in the rest of the Philippines. So if you look at the data, you can see that it's really, really challenging, even if some places have localized lockdowns. It's really challenging to control the spread of Omicron. And in the Philippines, it's Omicron BA.2. So when we did mutation analysis, as we have done in almost all cases, that's why we were able to detect the P.3 variant. The x-axis would be the number of samples analyzed. What did we observe? We observed that of the BA.2 local cases, we found two rare mutations in the global cases. So these are in the ORF1AB 12909V, and another in ORF3A, consistent. Probably 98% of our local cases, if not all, are carrying this BA.2 with two additional mutations. Even if we have BA.2 coming from overseas Filipino workers or also from international travelers, most of the time they do not carry these two additional mutations. So the presence of globally rare mutations suggests that a majority of our local Omicron cases are being sustained and driven through community transmission of the circulating lineage or sublineage of BA.2 with these two additional mutations. So what is the significance of these mutations? So we have here the two non-signature mutations. We looked at the database in GSAID and search which countries have this prevalence of A29OV in the ORF1AB gene, as well as the L140 in the ORF3A gene. So the highest count is, of course, the Philippines with 822, followed by the United Kingdom and Japan. And we know for a fact that some of the Japanese cases are really travelers from the Philippines. Also, those reported in Singapore, some of them are travelers from the Philippines. So the two non-signature mutations globally appear to be distinct to BA.2 and seems to be recently emergent. They are not key BA.2 mutations, and they are only appearing in about 4% of the GSAID BA.2 samples, about 1,281 of the 30,000 BA.2 in GSAID carry these two mutations as of the beginning of February. So although they are found in at least 28 countries, mostly in the UK and in the Philippines, but the most number of cases are found in the Philippines. So we wanted to ask, was this introduced in the Philippines, or is this a new a local mutation? So we looked at the map. So the earliest globally collected BA.2 with these two mutations was found in the Philippines, December 2, 2021. Now, regarding the UK, we cannot plot them in the graph because in the database, they do not indicate the time of swabbing or the time of sample collection. So we cannot see whether this was imported in the UK or somewhere else. So we cannot discount the possibility that these mutations were introduced from a country that is not frequently submitting sequence data to the global databases, or there is also the possibility that the mutations were locally evolved. The Department of Health has tried to track all these BA.2 with these two additional mutations to see if there is a difference in symptomatology and disease presentation. And so far, it is not any different than the other Omicron variants, or BA.2, as well as, of course, BA.1. So, will the Omicron variant be the last of the variants? Probably not. Is the Omicron variant the end game for this pandemic? We don't really know, because it continues to pose risks and the virus could continue to mutate. And that other variants will continue to emerge. Will these be even more transmissible, where they have a more severe phenotype? Or perhaps could they mutate into a more benign form? Or could it mutate perhaps with altered symptoms? These are things we don't also know at this point in time. Some experts are of the opinion that this pandemic appears to be on an evolutionary decline, a slide towards endemism, a new normal where the virus and humans coexist as we do now with the influenza virus. Actually, we don't really know, because this coronavirus has repeatedly surprised us. I'm not really sure how this pandemic will play out, and it is important that we continue to monitor and be vigilant and do not put our guards down. To summarize, genomic biosurveillance revealed a steep increase in the proportion of detected local Omicron cases from the last week of November 2021, where we first detected BA.1 and has rapidly become the dominant SARS-CoV-2 variant by the beginning of 2022 in the Philippines. The variant has now been detected in all regions of the country, with BA.2 being the dominant sublineage observed locally, not the globally predominant BA.1 sublineage. Although the majority of detected local Omicron cases have no travel histories belonging to the BA.2 sublineage, most of the returning overseas Filipinos that were classified with BA.1, most of our returning overseas Filipinos were classified as BA.1, suggesting that many of these imported cases did not have onward transmission of the virus. There's, of course, a recent uptick in cases of BA.2. So actually, this data has been used by our government to relax our border control and allow people to come back to the country and also tourists. The earliest detected case of BA.1 and BA.2 are both local transmissions, BA.1 on 22 November from CAR, BA.2 from Sarcobarians. The source and origins of these infections are therefore also currently unknown. We have done phylogenetic analysis suggesting that, of course, the patterns of transmission reflect exponential growth, consistent with the community transmission of this virus in our country. There's apparent clustering of Omicron cases from different regions of the country, such as porous borders and hidden lines of transmission. Two globally rare mutations in the local sample suggest that transmission is largely driven by this community transmission. We don't know whether these two mutations give the virus a competitive advantage or a survival advantage. And so far, based on our modeling studies in terms of our viral genome, we could not really pinpoint what would be the positive attributes of these two additional mutations in the variant BA.2. The infections occur in a wide range of samples, the data of which I have not shown, the majority of which were from individuals between 20 to 40 years old, and that the cases are mostly, again, asymptomatic and mild. So to end, I would like to thank our funding, that's the funding support from the DBN, Department of Budget and Management, the Department of Health, the DOST, the PCHRD, and the UP system. And this has been an effort done with the Department of Health Epidemiology Bureau, and the many laboratories around the country have been sending samples to us. So thank you very much.
Thank you very much. That's Professor Cynthia Saloma of the Philippine Genome Center. Napakahusay po ng kanyang paliwanag. Yung palang dahilan kung bakit biglang pwede na magbiyahe sa Pilipinas, hindi siguradong nanggaling sa labas. Itong Omicron, it could have been mutation from inside. And this is why genetic sequencing is so important, napakahalaga, no? So napakahusay po ng paliwanag nyo. Thank you so much for that excellent presentation. And I think it's very enlightening for us here in the Philippines to hear that explanation. And maybe it could have been explained more, because people were like, why all of a sudden relaxing, right? So I think so I think this is very important to be able to communicate properly. And thank you so much, Professor Saloma. Okay, so we're going to call everyone in now for our panel discussion. So Dr. Eva, Dr. Martin, Dr. Li Yang, and Dr. Saloma, please kindly open your videos, and we'll have a panel discussion. But before that, Raymond has an announcement.
Thank you, Executive Director Saloma from the Philippine Genome Center. Just trying to understand po our current situation in the Philippines regarding all of the variants that we have. Right now, we'd like to take a quick break for our special public service announcement for today.
Bayad po.
Salamat po.
Mama, bayad po.
Naku, anak. Tabi mo na yan. Para masuklian ko ang mga sakripisyo niya sa taong bayan.
Mapagbigay po kayo. Nakikita kong mahal na mahal ninyo ang inyong pamilya.
Tama ka. Kaya nag-aalala ako. Paano ba matapos tong pandemyang to?
Para matapos, umpisahan na ninyo. Magpabakuna na kayo.
Dahil mahal ko kayo, magpapabakuna ako.
Thank you, TVUP. The COVID Communication Public Service Announcement is one of the many outputs of the UP research entitled Communicating COVID-19 in Post-Quarantine Philippines, headed by the UP Vice President for Public Affairs, Dr. Elena Pernian, funded by the DOST PCHRD and the Department of Health through its AHEAD HSPR project. We also have, very, very quickly, just because we understand everyone is so busy, selected presentations from our past webinars. These are what we, lovingly call our SCD shorts. These can be found, these are short clips that can be found if you go to the YouTube channel of TVUP. You'll be able to essentially consume bite-sized information. Malaman po siya, and hopefully that's something that you could really view if you wanted to, well, not really consume all of the playback webinar, but really those important points from our speakers. Now let's go to the panel.
Okay, thank you very much, Raymond. And thank you so much to all our panelists for the excellent presentations and for actually answering the questions in the Q&A box. And I could see a conversation going on there. But I'm going to pick up on a question that came out in the Q&A, and I think is something that the Philippines is currently struggling with. So we're going to ask Martin and Liang to speak to this issue. So you have moved into antigen testing and self-testing. What is the role of antigen testing and self-testing in returning to school and returning to work in your countries? So maybe Martin first.
Okay, so the school system has been an important help, actually. You know, the testing has been very useful. We've noticed that the infection rates has been very high in children, and that's been worrying, and it was perhaps a worry that we might have to close the schools. But by introducing the self-testing and getting everyone to test at least twice a week, and possibly more if there are symptoms, we've been able to keep children who are positive at home. And this has allowed the rest of the class to carry on. And actually that testing means that currently, if you are negative by your test, you can go back into the school. So there isn't a 2-week window. It can be 5 days or 6 days. And if you're negative, you can go back. So actually testing has been very useful in keeping the schools open.
Right. And how long have you been doing antigen testing in the UK?
So we started really during the mass testing is from maybe May or June last year.
Okay, thank you. Very interesting. How about for the workplace? Do workers have to do self-testing also, or what is the norm?
So for education facilities, like where I work, we have to test twice a week at home, self-testing before we can come in. But we also expected, if you're coming into the office or into your workplace, you should do a test before you do that. And that's to try and minimize the contact rate. So lots of places are able to do that, and tests are available widely, so anyone can pick up and use those.
I mean, are they free, Martin? The tests are free, or people have to pay for them?
So at the moment they're free. They're supplied by the government.
Nice. Okay, so that will be very, very important point for us. How about Liang? In Singapore, that was the first time I heard that antigen tests were being used. So please tell us how you're using the antigen tests and what's its use or value in education and in workplaces.
Sure. It's much like what Martin had mentioned. Our antigen tests are widely available. They're sold in the pharmacies and some provision shops, and it's to encourage people to self-test and then not to go to work or go to school if they are positive. Very briefly, in Singapore late last year, we tried to have children test themselves, or parents test the children before they went to school. I think we thought this was a little bit of a disaster. So after
a disaster. Okay, why was it a disaster? Why was it a disaster?
It's very difficult to implement, and there were lots of complaints, especially for parents of young children. And since in Singapore, all the children have to attend school wearing masks, and there is all different sorts of distancing measures, in the end, we dropped it. But for university students, if they go on campus, every week, they still have to submit a test results.
Oh, great. Okay. And is this something that they have to pay for themselves, or it's provided by the government?
the government subsidizes or pays for a lot of the mandatory testing. So
Wow.
for instance,
Okay.
last year, my kids are young, right? I received this packet of like 20 test kits for the children.
Oh, for
And-
free, for free.
For free, yes. And for
Yeah.
university students, for example, there is this vending machine that dispenses test kits. And if you have a university code, then it's free as well, but it just gives you 2 at a time.
Oh, wonderful. Okay, so this plays a very, very big role, I think, moving forward as we open up and we try to stop the spread. Right, we have testing in a very different way, and that's currently being debated in the Philippines. Okay, so Raymond, you had a question you wanted to ask.
The question would be, the Philippines is also exploring, right now, how the government can do the same, especially for 110 plus million Filipinos. Was educating the public with regards to how to correctly do the self-test a challenge in the UK or in Singapore? Because that's something that we're trying to elucidate from the FGDs that we're conducting right now. Martin?
So it's interesting. When we started, I was very worried that people wouldn't be able to do the tests very effectively. And, that was a big concern, actually. However, it seems that even poorly taken tests seem to work quite well and probably much better than I imagined. We've changed the swabs a little bit. We now just use the nose and not the throat. And actually, I think that makes the test less sensitive, but we still get a very large number of positives. And my students and children, still seem to manage to get a positive result despite apparently poor technique. So while I'm sure it's less sensitive than if a healthcare professional did it, it's probably still good enough to be informative. And just to go back to Liang, so we don't test the very young children. So we have an age cutoff of about 12. If you're under 12, we assume that test is going to be difficult. So it's only for older children.
Right. Okay, thank you. Now let me ask a little about masking, because Liang said that kids in school go there with masks on. Is that's like mandatory? That's a requirement, and are masks provided by the school? How does that work?
Yes, Singapore is very strict with masking. So any public space, even outdoors, people have to be masked. And this being Singapore, there are people walking around to check who's wearing masks and to issue warnings or issue fines.
Okay.
That's very Singaporean.
And the masks for the kids, are those free when they go to school?
There were masks given out at different points in time, but no, the masks are not free. But masks are very cheap in Singapore now.
Yeah, okay, that's great. You probably produce your own masks, right? I guess.
Some of it, but a lot of it is still imported, yes.
Still important. And Martin, let's talk about masking. What's the thinking on masking now in the UK?
So the UK is very poor at wearing masks in contrast to Singapore. We're terrible at it. And but I have to say, we try to restrict the mask using to particular places. So on public transport, we have to wear a mask. Where you might be squashed next to other people, and in schools, and in fact, schools it's a bit easier to imply those rules. So there was masks when you met with other people in the schools, but that's been dropped recently as an opening up measure. So I think masks are very useful. We use the simplest is we homemade our masks that we use. It's just a cloth mask, 3-layer cloth mask that we use all the time and just reuse after washing. So I don't think they're overly expensive necessarily. But the UK, yes, very poor mask wearing, and I'm sure that's why our background rate of disease during that Delta wave was much higher than many other countries.
Right. Thank you very much. I mean, I'd like to bring both Eva and Professor Cynthia into this conversation because genomic testing, we are very fortunate that, well, Chancellor Menchit Padilla is here and she'll probably say something about this later. But I think you're doing much more genomic testing than we are. So what's the level of genome testing that you're doing in the UK and in Singapore? And then we're going to ask Professor Cynthia and Dr. Eva to talk about this also because, you know, geographically, we are an archipelago. We have the Genome Center doing its best. It's very new. But tell us a little about the history of genome testing in the UK and in Singapore and the levels of genome testing that you're doing.
So
maybe Liang first, or Martin. Go ahead, Martin. Go ahead.
Okay, sorry, don't want to go first always. It's the UK did do an awful lot of testing. You need a PCR test in order to do the genomic sequencing. And early on, that was the only type of testing that we were doing and restricted mostly to hospital use. And so at that time, most of those samples were genome sequenced. But as PCR has become the less common, the sequencing as a proportion has gone down quite dramatically. Most of our testing now is with the rapid antigen test. But if you're in hospital, you still get a PCR test, and we're still sequencing a good proportion of those. Although I have to say the government now is talking about reducing that. And I think that's a mistake because we should be monitoring that. It's been very useful. The alpha variant was detected through that sequencing, first detected in the UK. And I think it's important to keep an eye on those new variants coming through.
So that sounds like it's becoming sentinel, like a sentinel testing model, right? For if it's mainly the hospitals where you're doing genomic sequencing.
Yes, I mean, when we started, I think most of the genome sequences came out of the UK. We had a very big effort to do the sequencing in the UK, but now it's much less, mostly because PCR is much less.
Right. Thank you, Liang. Tell us about genome sequencing in Singapore.
I think UK has been the gold standard. Singapore, we have a national public health laboratory that does the whole genome sequencing of the virus isolates, but we also have academic centers that do some of the sequencing. And the experience is similar with Martin's, except that we have always just done sentinel sequencing. So we took a proportion of all the cases in the hospitals with the positive PCR test, and then we attempted to do a whole genome sequencing for them. As the case count rose, again, the capacity couldn't match the number of isolates, and therefore the proportion of positive PCR tests being sequenced fell. But we still do it routinely, not just from the hospitals, but also from clinics, GP clinics, sending their results in so that we can get some sense if new variants appear in Singapore or are imported.
Okay, so in your case, you're doing sentinel plus some communities. Maybe we're going to ask Professor Cynthia to talk about how you're doing it in the Philippines, and then ask Eva what's the vision. So Professor Cynthia, go ahead. How are you doing it in the Philippines?
So what happens is every region has regional epidemiology surveillance units, and they are the ones coordinating the local effort of collection from laboratories and hospitals, which has, for example, experienced a spike in cases. So in the beginning, it was really directed because of spike in cases. Now the move is just every region has a sub-sample, something like 75 or 50 samples every week they send to us. So that's the situation now. But we are also moving towards sentinel sites, and Dr. Swee, the RITM, as well as the other subnational laboratories will also be joining the effort. So we have 3 sequencing centers from the PGC Visayas, Mindanao, and PGC Maine. And then I think the big hospitals in the DOH will also be doing their own sequencing effort to a smaller scale.
Okay. Eva, how are you going to train everybody to do this? What's the vision? Go ahead.
Well, we're happy to inform everyone that you know that we have expanded our genomic biosurveillance efforts to the different regions. And fortunately, we have the Philippine Genome Center Visayas and Philippine Genome Center in Mindanao. And that should be, those two facilities should be able to take care of genome sequencing in the regions. But of course, you did mention our challenges in the Philippines, like because we are, we have a lot of geographically isolated and disadvantaged areas. And for now, we can even if we have a facility in Visayas, it may not be that easy to send samples to the PGC Visayas as opposed to sending samples over to Manila because of the flights, right? So logistically, we're trying our best to figure out the correct way to do our genomic surveillance in such a way that there will be good representation. We will have data from the regions and not only from the national capital region. So the very near vision is really for us to open those facilities. It will be probably in the next 2 to 3 weeks. And we're very happy about that. The people have been trained to do exactly what the Philippine Genome Center main campus in UP is doing. So everything is set. And as Dr. Saloma said, I think we're also moving into a sentinel site with other subnational labs coming into the picture. This has to be a country effort and not just just a few. It will be a collaboration with many testing laboratories. Thank you.
Okay, thank you very much, Eva. That's great news. Okay, Raymond, did you have a last or final question for us? Because we're moving towards the top of the hour, and we don't want to keep Martin up further than we have. So let's go, Raymond.
One of the final questions, and this was aggregated from the Zoom chat as well as the ones in YouTube, has to do with since we're talking about variants of concern and what will be next. One of the things that have come up towards the end of 2021 was a variant that combines Delta and Omicron. That's caused quite of a concern, especially in Cyprus. Is that something that we should be preparing for, or is there anything that would be much worse than what we have right now, in light of the fact that there are countries already that have high vaccination rates? I'll post that first to Dr. Saloma before we go to Dr. Liang and Dr. Martin.
Okay, so regarding the Cyprus Deltacron thing that has been checked, it's apparently a contamination. So many of the people in Gisaid as well as in Pangol and withdrew the submissions that those were probably contaminated samples. Nevertheless, the possibility of recombinant viruses is a distinct possibility that could happen. We don't know, however, what will be the next one, because for one, we were already concerned with the Delta variant, and then all of a sudden Omicron came with so many mutations in the spike region. Fortunately, the clinical presentation is milder compared to Delta. So if you ask me, Dr. Raymond, are there to be more variants for as long as there are areas in the world which have been deprived of vaccination? And as long as transmissions keep on going, there will always be variants that will happen. What is good is, of course, our arsenal of drugs and armamentarium has improved, but still the question of vaccine equity is a big question mark for
Vice Dean Liang?
I think we expect that there will be new variants in the future, and whether they're milder or more severe, we won't know. But I think on the positive side, the global surveillance system is much better now than it was over the past 2 years, and it keeps getting better and better, right? And I'm sure most of us remember that when the Delta variants arose, for months, we couldn't determine whether it was a variant of concern, how the different treatments affected it, and whether you would evade vaccines. And then for Omicron, we know fairly quickly. and similarly for this BA2. So I think while this system is in place, we can be reasonably confident that we will get information on new variants in a fast enough way that hopefully we can react even as it spreads around the world.
Thank you. And finally, Professor Martin.
Yeah, I think the answer's already been covered. I agree with both Cynthia and Liang. I'm expecting new variants to come up, and as I showed on my talk, they come out of surprising places. So we have to keep an eye on them.
Okay, thank you very much. We are close to the top of the hour, and I'd just like to extend our profound thanks to our speakers, to Dr. Martin, Dr. Liang, and of course, Professor Cynthia, and of course, Executive Director of the NIH, Eva. We're now going to have a synthesis by the Chancellor of the University of the Philippines in Manila, Dr. Menchit Padilla. Menchit, the floor is yours.
My video is not working. Okay, go ahead. Thank you. So good afternoon and probably good morning to Martin. Today's webinar was opened by Dr. Eva Cutiongco-de with the cover page of Time magazine. It is an animated story of the Marvel characters with predictions for 2022. Here are the two scenarios, the two predictions. Scenario number 1, the SARS-CoV-2 virus has achieved equilibrium with humans. The second scenario, the virus could keep changing in unpredictable and possibly deadly ways. So you've got the whole of 2022 to find out exactly which one will be the right scenario for us. Our first speaker is Professor Martin Hibberd. He gave a brief overview of the virus, mechanisms of action of spread, and modes of transmission, which we have extensively discussed in prior webinars. There is a worldwide effort to whole genome sequence of SARS-CoV-2, and we now know that the different strains all evolved from mutations that occurred very early in the pandemic. So I'd like to encourage all of you to watch the replay and review first, the key mutations within the variants. Second, the distinct mutations found in Omicron BA.2. And third, the PCR diagnostics that can identify the 3 genes of the virus. And we've heard this again and again, as well as in the past conferences, the spike, the N2, and the E. Now, Omicron has been around. What we're knowing is that Omicron has been around, but initially not transmissible. So eventually it had mutations that became more transmissible. So Dr. Martin warned us that the next variant could be one of the silent mutations, which will eventually become more transmissible. Dr. Martin gave a preview on the effect of Omicron, of the Omicron BA.2 in the UK. And he said that, and I think just the same like here in the Philippines and Singapore, the PCR is distinguishing the stealth, the BA.2, but there is no clinical difference. Now, the UK is fortunate to have a national survey. And I think this really allowed them to see the real numbers and pictures in their population. So the random testing of households has revealed that 5% are positive for the Omicron. And the policies for testing have actually also increased the numbers. They said that with self-testing, the numbers really went up. But what they can see is that it is milder and there is less hospitalization. Dr. Martin said that the combination of vaccination and the lockdown are probably the 2 reasons why the numbers have brought down, the numbers of deaths have brought down. Now, there was a question on schools, and I know the audience is very keen to know what's happening, but the schools in the UK have remained open because of massive testing. Countries vary, and one of his last slides actually showed that the risk of severe disease will really vary between countries, and it's for many reasons that we all know now: the vaccination rates, the age profile, the comorbidities, the element of mixing among the people in the population, healthcare access, and of course the facilities for self-isolation and the support from the government. Now, in closing, Professor Martin said, this is what we have to accept. It is a nasty new disease that is here to stay. We expect new variants likely each year. The vaccination will need to be updated every year. And we need new therapies because there will be those that will escape the vaccination that's given to the patients. Our next speaker is Vice Dean Hsu Li Yang from Singapore, who shared insights from Singapore. Omicron BA.2 entered the borders in January only of this year. They're very lucky because 90% of the total population is fully vaccinated, with 64% having received already a booster dose, maybe a number that we hope we can have in the Philippines. The lessons from SARS in 2003 helped them plan better. Singapore invokes the whole of government approach, very similar to what we have in the Philippines. But let me just mention what they consider as their definition of the whole government approach. A national effort coordinated by the multi-ministry task force set up to direct national response to the outbreak. Number 2, coordinated community response to protect all in Singapore, and working with international community to respond to the outbreak. Now, the COVID-19 strategy in 2020 involves the enhanced surveillance, containment, active case finding, and reduced importation. Vice Dean Li Yang mentioned key moments in the COVID-19 story in Singapore. The first one is the migrant workers in the dormitory outbreak in April 2020. The second one is the Delta wave. And this is interesting because they said that the prior strategies of public health standards were no longer effective. And that's why they pushed for vaccinations, which is their key moment 3. They needed a solid vaccine strategy. The key moment number 4, in terms of the vaccines, I wanted to mention that they made an early negotiation to buy vaccines. They wanted to make sure they had the supply for their population. And their Singapore Airlines flew wherever the vaccines were to fly them back to the country. The key moment 4 was the vaccination rollout, very similar to the Philippines, which is a progressive phasing of the vaccination to the population. The key moment number 5 is misinformation. We also have this in the Philippines. And last but not least is the key moment 6, which is the use of the various testing strategies that will be needed by the population at a particular time. So just like in the UK, there is, as far as the BA.2 is concerned, there is no difference in treatment as of this time. Our last speaker is Professor Cynthia Saloma, the Executive Director of the Philippine Genome Center. And she started by sharing actually the beginnings of the Philippine Genome Center, or PGC. It was established in 2009 to primarily provide sequencing services, especially at times when the borders close, and this is actually the time. To date, she reported that there are 23,000 have had whole genome sequencing with Alpha, Beta, and Delta. But just to highlight that since January, cases have all been the Omicron variant. So I would like you to watch the replay to review the evolution of the different variants in the Philippines, because she talks about when we had Alpha, Beta, Delta, and then exactly when the Omicron entered the borders of the country. Now, as far as the Philippines is concerned, Dr. Saloma said that it peaked actually, Omicron peaked, the variants peak usually 2 months later as compared to our neighbors because of our border controls. As for Omicron, the peak was actually in the second week of January. So to date, we have more than 3,000 cases, mostly local, across the regions, with 98% from being Omicron BA.2. So just allow me to mention a few points that she mentioned in the summary slide. Well, number 1, genomic biosurveillance revealed a steep increase in the proportion of detected local Omicron cases from the last week of November 2021 and rapidly becoming dominant, the SARS-CoV-2 variant by the beginning of 2022. The second is the variant has now been detected in all regions of the country. And she pointed out that the finding of the BA.2 primarily local as compared to the BA.1 that is found among the overseas workers is one reason we opened up our doors to foreign travelers, because what we're getting is the local variant, not the one coming from overseas. The overseas workers usually would pick up a variant from where they came from. Now, the third point is the apparent clustering of Omicron cases from different regions suggests the porous borders and the hidden timelines of transmission. And definitely it covers a wide age range, primarily between 20 to 40 being the working mobile population. So just like in Singapore and the UK, our cases are mild. The cases we have picked up are primarily asymptomatic and with mild symptoms. So in closing, here are some messages to remember from this webinar. First, let us brace ourselves in anticipation that this pandemic will soon be endemic. Second, as far for treatment of Omicron BA.2, there is no difference at this particular time. Third, regardless of variants, as Dr. Eva said in the opening, important strategies remain: improve global surveillance efforts and increase genetic sequencing of the virus, because knowing the genome of the circulating viruses can help provide the earliest hints of any changes and clues as to which of these changes could be dangerous for humans. And lastly, as shown in the closing slide of Vice Dean Li Yang, the future is living normally with COVID-19. Thank you and good afternoon. And back to you, Dr. Susie and Dr. Raymond.
Thank you very much. That's our very own Chancellor, Menchit Padilla, with an excellent summary. I don't know how she keeps all those notes while she's listening to the webinar, but thank you so much for that summary. All right, next week, we have a very, a very urgent issue we want to take up. So some of you may have been monitoring the possibility of war in Europe between, at the border of Ukraine, Russia, and the NATO countries, sort of Western countries, are building up military strength, and it's been described by many as the most dangerous moments in World War II. Now, we don't mean to scare people, but we believe that it is time for us to understand what's happening there and how that might affect us and how that might affect the pandemic. So our topic next week is something like gera sa panahon ng pandemya. Hopefully it doesn't happen, but by all indications, it seems that the tension is becoming more, more severe. And we should know ahead of time what we're going to expect. There are Filipinos all over Europe, not only in Ukraine, but in Poland, in Hungary, in Romania, and Belarus, which all neighbor Ukraine. So we want to talk about that, and we have some very special guests next week who will talk about gera sa panahon ng pandemya. Kahit na malayo yan, no, we might think, oh, malayo yan, won't affect us. No. If this pushes through, there will be effects on the economies, there will be effect on supply chains. And I was just checking this, that Russia has 200,000 new cases of COVID every day, 200,000 a day. And Ukraine, with a population of 41 million, has about 30,000 new cases a day. If people start fleeing from Ukraine and moving into different places, I don't know what's going to happen. Okay, so we should be prepared, thinking about what preparations are best for us. And of course, people are also a little bit concerned that if there is armed conflict in Europe, then other parts of the world where there are flashpoints or there are tensions, like the West Philippine Sea, for example, could be affected. We don't know. So we have some experts who are going to talk. Of course, we'll have Ted Herbosa opening this. We will have Attorney Tony Lavinia, who's one of the best analysts, I would say, on global politics. We'll have Dr. Johnny Naniagas, who you've had before, who's with the armed forces, and Dr. Daniel Lising of the Global Health Law Center of the University of the Philippines College of Law, and some others. So don't miss it. Don't miss gera sa panahon ng pandemya. Okay, over to you, Raymond.
Thank you, Dr. Susie. And once again, we'd like to extend our deepest appreciation to our panel of experts for today. We really learned a lot, and that's something that hopefully all of our viewers will be able to take away from this webinar. Again, another excellent recap and synthesis from our UP Manila Chancellor, Dr. Padilla. For next week, we hope you'll still be able to join us. I don't want to say it's a little bit unorthodox or something na talaga po natin pinag-uusapan, but it will be something that will affect us and think about it, especially during this time that we are still in the middle of the pandemic. So sana po makita-kita po tayo ulit next week. But before we conclude, we'd like to thank the very hard-working team behind the Stop COVID Deaths webinar series. Without each and every one of you, we won't be able to churn out quality content each and every week. And also, for those who want to be able to watch either in whole or in part in the playback, you'll be able to watch each of our 87 webinars, and then right after this one, webinar 88, in the YouTube channel of TVUP. You'll have to go to www.youtube.com/TVUPPH to be able to see all of our webinars to date. So maraming salamat po ulit. Magkita-kita po tayo ulit next week. This formally closes our webinar for this week. Again, next week po, Friday from 12 noon to 2 p.m. It's a date.
Together, we will stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others' pain before my fears, the others' lives before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others' pain before my fears, the others' vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others' pain before my fears, the others' lives before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others' pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will hold the line.